Hi, this is E. David Crawford. Joining me in Grand Rounds in Urology on our special feature, Need to Know, is Dr. Raoul Concepcion. Raoul is a clinical professor at Vanderbilt and involved with a research organization called Integra. We all are aware of the increased number of infectious complications being recorded with transrectal biopsies. Raoul actually will present some data called an antibiotic-gram, which will give us some information about how to reduce these infections by about 50%. Raoul, thanks for being with us.
David, thank you so much for the kind introduction. So this is a project that we started about a year ago, and it was really a joint project between Integra Connect, which is a health information technology company, jointly coordinating with the large Urology Group Practice Association, LUGPA, as well as Ted Schaefer over at Northwestern. And as we all know, that there has been recently reported incidents of increasing infectious complications after prostate biopsy. And much of this, because of the fact there's no standardization, what we wanted to do was to obviously take a practice sampling of multiple groups throughout the United States and look at if we actually implemented a standardized protocol using an augmented antibiotic prophylaxis, but basing it on a local antibiogram in a particular community. So how we did this, the objective was to determine if implementation of a standardized prostate biopsy protocol utilizing antibiotic prophylaxis based on locally derived antibiograms would result in a decrease in the incidence of infection-related complications. We chose 9 community practices, geographically distributed, and each practice determined through a retrospective review their historic infectious complication rate for 2 years prior, using their existing antibiotic protocol, which was self-identified. At that point, having established the historic infectious complication rate, we implemented an augmented prophylaxis protocol based upon locally derived antibiograms for each individual market. And in this augmented prophylaxis, it was the usage of 2 antibiotics. We had one protocol for people that were non-penicillin allergic and one protocol for people that were pen allergic. And then what each group did was they basically enrolled 91 consecutive biopsies per group and monitored the patients for 3 weeks post-biopsy to determine if an infectious complication had occurred. So what we also did was that we identified risk factors which have been recognized and published in the literature for parameters and factors that might increase a patient to an infectious complication. And these factors include prior usage of antibiotics for any condition within the previous 6 months, if they were a diabetic, if they were a self-identified healthcare worker, including veterinary care, prior history of prostate infection, prior infection from a prostate biopsy, current use of a TNF inhibitor, current use of corticosteroids, and if they had a recent positive culture or history of organ transplantation. We then standardized the biopsies for all the practices with the use of Fleet's enema, and then also implemented the prophylactic antibiotic protocol, which again was based on a local antibiogram and was therefore specific for each individual practice. And then in the post-biopsy phase, we called patients 2 to 3 weeks after the biopsy to determine if, in fact, they had had an infectious complication, which was actually determined with the utilization of the investigator at each site. What we found is that with the groups identifying their historic complication rate through a retrospective review, that cumulatively the rate was about 3.1%. After implementation of the standardized protocol with the localized antibiotic prophylaxis off the local antibiogram, basically we were able to reduce the infectious complication rate from 3.1% to 1.4%, which is a 53% reduction in infectious-related complications. So the conclusion of our very limited study is the development of a standardized biopsy protocol with antibiotic-augmented prophylaxis based on a local antibiogram results in a significant reduction in the number of infectious-related complications. Now, clearly, this study is limited by size, identification, very subjectively, obviously, of complications, historic, but I think it lends yet another opportunity for practices and practitioners to think about how they should utilize and develop antibiotic prophylaxis, and it does not necessarily always have to be basically rote for every patient, and really also brings into the question of the use of other types of practices, including rectal swabs and those types of things. Thanks so much for listening.
Well, great work. Just a quick question. I know a lot of people are shying away from transrectal biopsies in favor of transperineal, which are a little bit more difficult to do, but with the claim that there are fewer infections. What you've done is actually shown, importantly, you can reduce something by 50%. But what are your thoughts about this trend towards transperineal biopsies?
I think, David, there are clearly advantages of transperineal, as you pointed out. Number one, I think because we're not violating the rectal mucosa and potentially bringing into play the rectal flora, that obviously has a clear advantage. The second obvious advantage to transperineal would be, especially as you know, the higher incidence, probably up to 22, 23% of anterior lesions, that the anterior area is actually better accessed by a transperineal approach than a transrectal approach. So I think those two things taken in combination present some advantages of transperineal. Now, I think the clear disadvantage is that from a workflow standpoint, given that many of the younger urologists have never done transperineal, unlike you and I, that we sort of grew up in that era, this presents a workflow issue. They do have to buy some extra add-ons to the equipment in order to perform transperineal biopsies using their existing equipment. But I think it's mostly more of a workflow and a time commitment. But I think, as you said, there are definitely some clear advantages to going the transperineal route.
Great. Well, Raoul, thanks for taking time to share this with our Grand Rounds and Urology audience. We appreciate it. And you have a great holiday season.
Great. Thank you, David. Appreciate it.